is following those rules. We don't hear anything here. If you do have a question, feel free to type it in, and please type it in any time. If there are a lot of questions that come up, we will stop and pause mid-presentation and then answer the questions. Otherwise, we'll do it at the end. And then finally, the advertisement for this had two sets of objectives, one for CKD and one for proteinuria and diabetes. And because we have a short period of time, I've combined it into one presentation of the management of CKD and those with proteinuric kidney disease. So we'll go through, hope to be as interactive as we can with an empty room, but happy to take any of your questions as they come up. And we have an hour together today. For this presentation, there are no relevant or irrelevant disclosures. And what we're going to do today is we're going to look at the current guidelines for the evaluation, diagnosis, and classification of CKD. We'll do this quite briefly and try to take out the key points. I'll talk a bit about some caveats for interpreting GFR in your practice. And we'll talk a bit about how to measure and the significance of proteinuria and how to treat it. We're going to do some brief short snappers of what to do with the patient in your office with anemia or hyperkalemia or abnormalities of calcium and phosphate and primary care treatment of these. And then we'll talk a bit about referral guidelines and kind of how they came up and a bit of a common sense approach for who to refer, who will progress, and who we should reassure. So the majority of people with CKD are actually managed by general practitioners, by nurse practitioners, by primary care providers. It's estimated, and you might see it in different news releases, that approximately 1 in 10 patients or adults in Canada have CKD, and that actually is true. And in our kidney clinics, we see about 1 in every 300 adults. And so the majority, vast majority of patients are being managed in the primary care home. And it's important to remember that most patients with abnormal kidney function will die before ever reaching end-stage kidney disease. And we're going to talk about how to tease out which patients are more at risk of progression and which patients you can reassure. We're not going to talk about dialysis, transplant this session, except if there's specific questions, but as you guys know, any form of renal replacement therapy is associated with significant mortality and loss of quality of life. And so what I hope to show is by identifying CKD early, we can get those interventions in that will improve cardiovascular outcomes and delay progression of chronic kidney disease. So just one slide on the burden of chronic kidney disease. So the average life expectancy of someone who requires dialysis is about 5 years, and that's all comers. If you're over 75, the average life expectancy once you start dialysis is about 2 years. And what we're learning more and more is that whether someone starts dialysis or chooses a conservative care pathway, there really isn't much difference, if any, in life years gained. So you may see our approach to managing patients with end-stage kidney disease change a bit, and it has so as we've started to see what happens to these elderly patients. If a young person starts dialysis in their late 20s, their life expectancy is about 20 years if they do not get a transplant. And if you get a transplant, that might extend it about 20 years beyond that. So it's definitely a life-limiting illness. And so one quick tidbit you can do if you have a patient who's young who we have said or you think will reach end-stage kidney disease, things like avoiding blood transfusions, anything that would sensitize them to another transplant would be important early on, even well before their kidney function goes down significantly. It's also true that the patient with early stage CKD, so GFRs above 30, are 5 to 10 times more likely to die from cardiovascular disease than progress to end-stage kidney disease. So a lot of the patients we manage is really in a cardiovascular risk reduction model. And so I've used this slide before, but it really does drive home the point of not all GFRs of 30 are created equal. So these are 3 different people. The little old lady first on your left is 86. Her GFR is 30, and she's a normal urine ACR. Below 3 is a normal ACR. Compare that with the 72-year-old gentleman having his wine. GFR is also 30, but his urine ACR is 70. And so to convert that to a 24-hour value, you add a 0, and that would be 700 milligrams. of albumin in 24 hours. And then the young gentleman on your right, 48, his GFR is 30, but his urine ACR is 450 from diabetes, so quite high. And just with those facts, when you use risk prediction models of what's their risk of progressing to significant kidney disease, the 86-year-old with a GFR of 30 and no protein, really minuscule risk, 2.8% over 5 years. The gentleman in the middle, still way more likely that he won't develop end-stage kidney disease than he will, but maybe someone that would be managed in a clinic to keep his kidney function as good as possible for as long as possible. And then that other gentleman with the GFR of 30, the young gentleman with protein already, he should be rapidly referred to an interprofessional team for care. We should talk about transplantation options. We should really get up front because you know almost certainly if he doesn't have a cardiovascular event before that, he will reach the need for a kidney transplant or end-stage kidney disease. So we can tease out with a GFR of 30 what's going to happen to the person and then what interventions are needed. So just a reminder, the recommendations for screening, universal screening for chronic kidney disease is not currently recommended, really only for patients at high risk. This list is a list you guys know well. Remembering we have a lot of that high risk ethnic groups in BC. And I do know we have people from a lot of different provinces on today, and I think every province in Canada has their group of specific high risk groups. And the recommendation is every year or two, and usually a bit more frequent in patients with diabetes or hypertension, to do a screen for kidney disease. And what a screen means is a creatinine measurement, a urine analysis, and a urine ACR. In the recent past, all labs, at least in BC, report out the eGFR automatically when you order a creatinine. So a GFR is not a separate test. It's not that way everywhere in Canada yet, but it's getting there. And that is the best marker we have, the quick and easy marker. It's important to know that almost all of us will have a GFR number that dips. So modest fluctuation in the creatinine or the eGFR measurement is common. One value should not prompt anything except a repeat value, unless maybe it's 15 or less, quite low. But CKD, by the virtue of being chronic, it's never based on one test. It always requires time, and usually 2 or 3 months to determine whether it's an acute event or whether it's chronic kidney disease. And in nephrology, we actually don't use the GFR and the albumin categories that are out there too much. We usually say the person's GFR is X and their proteinuria is this much. But as you know, there are 5 stages of chronic kidney disease, and it's a bit unfortunate that it starts at stage 3 for someone that just has CKD on the basis of their GFR alone. So to remember, in the absence of any kidney damage, so polycystic kidney disease, an underlying predisposition like a glomerulonephritis, an eGFR above 60 is not kidney disease. So an eGFR between 60 and 89 is not a mildly decreasing kidney function unless there is something else wrong with their kidneys. They have another kidney-related illness. The same as a GFR above 90. It's normal unless they have another illness that doesn't impact the GFR. So it's really important to have some sort of phraseology to tell your patients when they Google it and notice they have stage 3 chronic kidney disease because their GFR is 56. Really, they have the first stage of kidney disease based on that GFR loss. And that's definitely a hard one that I still haven't mastered, being able to convince patients that their level of kidney function is actually quite stable and not really the 3rd stage of kidney failure. So the definition of CKD is a GFR less than 60 for more than 3 months, or some evidence of kidney damage, either persistent proteinuria and hematuria, something on imaging like polycystic kidney disease. Every value of an eGFR that's low when you're working it up should have both the urine ACR and a urinalysis attached. I find we're pretty good at doing the ACR, but the urinalysis often gets missed. And the reason that's really important is to find out what the etiology of the kidney disease is. Just another way to say values between 60 and 100 in the absence of any other abnormalities do not indicate chronic kidney disease. And one quick pearl for referral criteria. Anything that would require a cystoscopy or surgery, nephrologists are not very good at all. So, and we don't do it. So unless you just want to delay referral to a urologist, anything that is a complex cyst, an angiomyolipoma, hydronephrosis, renal mass, obviously if you just need to get a hold of someone and ask a question, any local nephrologist would be happy to answer. But those are all directed urology referrals. And then the other caution is, I'm sure you've all seen the term medical renal disease on ultrasound. And sometimes when someone has quite significant kidney disease, you can actually see changes. Often when you ask the radiologist, when the GFRs are in the 45 to 60 range, it's really more on nuance because they knew that the GFR was low, so they say findings consistent with medical renal disease. So often we get someone that had an ultrasound down for something, their GFR was a bit low, it popped back up, and then the worry is for the medical renal disease on ultrasound. If your GFR is normal and your urinalysis and ACR are normal, there's not much to make of that finding in isolation. So maybe we'll just check quickly if there are any questions, and then we'll go on. Good. So just for an example, I wanted to talk about the use of the eGFR when it is above 60. So the GFR was actually calibrated for only GFRs below 60 mils per minute. It was to follow patients with known chronic kidney disease. So this is a common scenario we get a consult on. You have a young man with well-controlled hypertension, and his eGFR, you're mapping it in your EMR grid, and it goes 89, 72, 65. So it looks like quite a sharp decline over the last 2 years. You do a urinalysis, it's fine. You do a urine ACR, it's fine. You have two options. You can be a bit worried and send him to a nephrologist because you think his kidney function is falling, or continue to follow the patient but reassure him, realizing that estimates are much less accurate at higher levels of GFR. And this is actually true. You can't actually, in some jurisdictions, if a GFR is above 60, the actual number it is not even reported. And so it's important to know that these numbers over the next few, now of course if it keeps falling and there's another reason, or they're getting blood and protein in the urine, it's a different story. But we often get these situations where this is what it looks like, and then over the next few years it pops back up. Sometimes they were a bit more muscular, something else has happened. So the accuracy of the GFR estimate is really good when the GFR is low, so 30 and below, even 60 and below. But at the higher GFRs, both because of biologic variability and because the equation was actually made for patients with and calibrated in patients with GFRs below 60, they're not meant to follow a GFR trend in patients without kidney disease, in patients with GFRs above 60. For those in British Columbia on the line, we have changed our equation. I just wanted to explain it, not because you have to know the nuance, but because you might have seen people that had kidney disease in your records and then now don't. So there was a new equation called CKD-epi that when you put the creatinine, when the creatinine is taken, they take the patient's age, gender, and creatinine because that's all they have, and they usually calculate it as the white race, and then they put in the number. And this new equation is a bit more accurate, especially at the higher GFR numbers. So when they run the same sample of patients with the old formula and then with this formula, it actually recalculates 24% to a higher GFR category. So that's, say, 24% of people that had a GFR between 45 and 60, so in the CKD range, that now don't, between the 60 and 75 range. And this is just a graph to show you when we use the old equation, this blue line is the amount of people at each stage. And then the black line shifted over shows that there's all these people that are now reclassified. So in BC, this primarily was older women and older men who were kind of in that borderline range, 45 to 60, and then were unclassified as having CKD, and we saw a lot of them. So we'll talk a bit about the use of the eGFR measurement in elderly. This is actually a false statement because the measurements actually weren't calibrated in an elderly cohort as well. And what we find, let's just take a little step back and look at what happens for your normal GFR. So on the y-axis is your GFR, and at 20 you should have a GFR of about 120. At 40 it's usually about 100, and then we tell people it goes down a mil per minute per year after that. So even if you live till the ripe old age of 90, you should have a GFR above 60. And so we tell people that, but that's for their actual measured GFR. So the actual one that you get on the paper doesn't work that way. So if you have a 20-year-old and their GFR is 72, that's actually normal on the paper. It just says normal or abnormal. If you wanted to actually know, like we do sometimes for patients who give one of their kidneys, you would have to do a more extensive, true measured GFR test. So even though these are the true physiologic numbers, the numbers on the page that you get from the lab won't reflect that. If that makes sense. And so what we found when we did those very measured GFR samples is that in people over 75 and especially people over 85, the equation that you get from the lab is quite problematic. So it really tends to underestimate the true patient's kidney function. So if the age is over 75 and the values are between 45 and 60, usually it's normal variation, still being sure to check the urine protein and the urinalysis. But in general, those are kind of within the realm, and if we did a true measured, it would likely mark in the normal range. We're seeing a lot more people in their 80s and 90s, and the equation's very problematic. For those of you that do a lot of nephrology, you'll see, a 90-year-old with a creatinine of 120, but it's saying her GFR is like 25. It really underestimates, and so in the guidelines we've tried to say take it with a grain of salt in an older person and take it into context. Is it moving? Is it changing? Is there associated proteinuria? It doesn't mean we don't tell the patients I usually say they're at kidney risk. So I'm a nephrologist, so I don't tend to see kind of these people too often, but I will say, you have this risk to your kidneys, so I wouldn't go up and take a lot of NSAIDs. If you need an angiogram, I would just ask why and make sure we do the precautions before that. And if you get sick, you're at more risk of acute kidney injury. But usually those patients do not have significant chronic kidney disease. So let's turn a bit into the measurement of proteinuria. And so we often get referrals that say the proteinuria has been, the 24-hour urine's been ordered, and at least in the last 10, 15 years, there really isn't a role in primary care for 24-hour urine collections. We do still monitor it sometimes when we're titrating immunosuppressants for glomerulonephritis conditions, but in primary care we very rarely would want a 24-hour urine to check for protein or to check for creatinine clearance. And so to remind you, the good old dipstick, the problem is it's very concentration dependent, but if it's a positive dipstick, it will pick up 300 milligrams of albumin or an ACR of 30 or higher. And so that's where the old word that we don't use anymore, microalbuminuria, came from, because it wasn't picked up on the dipstick. It was below an ACR range of 30. And so now we do urine ACRs. Mornings are technically better or a bit more standardized, but really any time of day is all right. And the important thing about this is when I said GFRs fluctuated, ACRs fluctuate even more. At any one time, about 40% of the population over 70 has a positive ACR. And so things that you know about, was their blood pressure poorly controlled when it was done? Were their sugars poorly controlled? Did they just have an MI or anything with an inflammatory state? Had they exercised? Had they ran up the stairs? We get a lot of our CMP officers, a lot of CrossFit people who have a positive ACR test and then just need to take it easy for a few days and it goes back down after a UTI with heart failure. So there are a lot of reasons that will give you a positive. It's not really a false positive, it's just a transient value. So make sure that there are at least 3 urine ACRs done in succession. And in terms of how long in between, if the first number is 500, you probably don't want to wait. If the first number is 20 or 30 or 10, then within the next few months would be appropriate. And this is just a quick and dirty grid if you wanted to keep it for the way we classify proteinuria now. ACR less than 3 is normal, and just a little cheat rule, if you just add a 0 to the end of it, that gives you how many milligrams a day of albumin. A moderate increase, this was the old words of microalbuminuria, which we really don't use too much in practice anymore, which is 3 to 30. That will sometimes pick up on the dipstick and sometimes won't. And above 30, used to be called overt proteinuria or macro, is a 24-hour protein of about 300 milligrams of albumin or more. But the ACR is a very simple and useful test for doing it, and whether you know A1 to A3 or not doesn't really matter. Just what the ACR number is all you really need. So let's talk a bit about the significance of having low GFR and urine protein. So this is a true or false statement, and I'll tell you the answer since we can't have a show of hands. A patient with a GFR 45 and a normal ACR has a similar risk of adverse events as a patient with a GFR 70 and an ACR 15. And in general, that's true. So both the GFR number and the proteinuria number confer risk. And we've known this. There was a flurry of literature in the last 10 years saying how bad proteinuria was, but on the left is Hippocrates, who used to just look at the urine, see bubbles, and say that person wasn't going to live a normal life. And in the 1800s, that's how they did health insurance and still do. If you have proteinuria, people knew it was a marker for bad things to come. Not really kidney failure, but the cardiovascular and life expectancy was lower if you had significant proteinuria. So we look at proteinuria as a marker really for cardiovascular events, for heightened mortality, and probably last, but in conjunction with GFR, for CKD progression. And this is just, I have very few tables, but this is just one quick slide to highlight that. So this is your life expectancy on the y-axis here. So say if you're a 30-year-old individual, all comers, you have 42 years left with a normal ACR, and you have 23 years left with an ACR above 30. Pretty amazing. About a 20 with all comers, again, this is population, this is not any one of you that may have some proteinuria, about a 20, 25-year reduction in your life expectancy. So young people with proteinuria have to be managed aggressively. But if you compare that to an 80-year-old, the lines are almost the same, right? So whether you have a little bit of protein or not, it does change your life expectancy, but not by much. So age is an important modifier with how bad having low GFR and albuminuria is. So let's get a little bit into the guidelines. We're not going to go through all of the treatment guidelines, but we'll take you through the ones that are most renally related. So this is from the most recent BC guidelines. Obviously, lifestyle and drug therapy, which primary care knows more than I do about, and counsels people on these: exercise, keeping a healthy BMI, smoking cessation. We're learning more and more about smoking, not just for cardiovascular health, but we're seeing people's proteinuria go away when they stop smoking. So we can actually see a marker and trend the proteinuria value. So if you're working with someone to stop, it's just another indicator that things are getting better with their vascular health. And sodium restriction. There are a lot of different guidelines about statins and cholesterol targets. Really, I think the easiest thing to remember is a CKD patient or a patient with proteinuria is high risk for cardiovascular events and therefore should be treated with the high-risk protocols with statins. Blood pressure targets, as you know, are a moving target. These are the current recommendations. There are some new studies coming out that question whether this should even be lower, but in our patients with CKD, even reaching these targets are sometimes difficult. So these are the current recommendations for blood pressure targets. And we'll talk a bit more about in whom do you start start an ACE or an ARB? When do you start it? What do you monitor? When do you stop it? In the upcoming slides. And then an A1C, of course, good sugar control. What I must say is that A1Cs don't often trend with how bad their diabetic kidney disease is. It's quite interesting that some people have very high A1Cs but never get renal compromise, and others have pretty close to normal A1Cs and actually have quite bad diabetic nephropathy. And we're learning more and more about the reasons for that and the genetic predisposition, but it can sometimes be quite unnerving for a patient who's kept their sugars under quite good control, and you think it can't be diabetic kidney disease to the point we biopsy, and it can be diabetic kidney disease, and it can be really bad diabetic kidney disease. So another question, how would you treat this patient? You have a 70-year-old individual. His cholesterol is up and he has peripheral vascular disease. His blood pressure is at target. His GFR is normal. He is on a statin. And ACR is done on 3 occasions. And you know now that below 3 is normal, 3 and above is abnormal. And it's 21, 23, 22, 25. You do it a few times. His urinalysis is normal. And you do a renal ultrasound just to take a look, and that's normal as well. The role of renal ultrasounds in diagnosing CKD, we probably do them a bit too often. You often do them and they're normal. If you don't expect a problem, often you wouldn't have to do it, but it is quite common practice that someone with chronic kidney disease, either through their GFR number, their proteinuria number, will get one ultrasound in their workup. And so which one of these would you do? Would you just say you're actually quite well managed and we're going to keep up your cardiovascular risk factor reduction and we're going to follow every 6 to 12 months? Would you start an ACE or ARB because his ACR is, almost 10 times the upper limit of normal? Or would you do both and refer to nephrology for evaluation of the ACR? So maybe after this session you would really just continue to manage him. Patients with ACRs below 30, if you don't have another reason to start an ACE or ARB, there really is little evidence that by adding an ACE and ARB with either no proteinuria in CKD or low proteinuria in CKD, that you're changing the course. Now that is different if you have diabetes or hypertension and have to reach for an agent, which we'll show in the next slide. So I tried to summarize years of different studies and when to treat with an ACE or an ARB depending on their protein level. So really, if their ACR is above 30, you can pretty much within reason, if they're 90 and you just notice it, then I probably wouldn't give them anything if their GFR is okay, or if their GFR is reduced. But if the ACR is above 30 and you're trying to prevent progression of kidney disease, then most evidence would say start an ACE or an ARB. Either would be fine, and any agent would be fine, really. If you're in this middle ground, which up to 40% of the population above 70 are, then it becomes a bit more controversial. If you have another reason to treat anyways, the patient has diabetes, the patient has hypertension, or both, then reaching for an ACE or an ARB is in the guidelines recommended. But if you don't have another reason to put them on this therapy, then they're really, and this was the guy we just looked at above, there's really no evidence that you're doing anything by adding an ACE or ARB for kidney protection. And we often get those consults or those phone calls, should I add an ACE or ARB for kidney protection? In the absence of significant proteinuria, ACE and ARB do not provide kidney protection. And then if your ACR is less than 3, prophylactically putting someone on an ACE inhibitor, just diabetes alone, no evidence. Diabetes, if you have to reach for something, regardless of what their ACR is, then an ACE or ARB considered first line. I think the jury is completely out about, it's in, I guess, about combination therapy. So for kidney disease, no evidence of using and potential harm of using combination therapy. And then often, most of the time, by the time I see the consult, the patient's already on the ACE or ARB, and they say, but the protein's still up. What do I do next? So there are a few tricks you can do next. Sodium in the diet has a huge modifying factor on urine protein. And so following a urine sodium a low sodium diet, getting help with a dietitian, you can actually watch the urine ACR start to trend down. It's quite powerful in its efficacy. Adding a diuretic to the ACE or ARB also has a synergistic effect. So if they have any indication at all for it, or if you could sometimes even lower the ACE dose and add an ACE and a diuretic, that can sometimes help the efficacy of the protein reduction. And then sometimes taking the ACE, there's a few studies that say if you take your ACE or ARB at night instead of in the day, it actually will reduce protein more. So those are some tricks you can do and add on. So we often get the question and think about it ourselves, is it ever too late to start an ACE or an ARB in CKD? So the literature shows that it really is never too late. There's no eGFR cutoff below which patients don't benefit from these medicines. We actually put people on peritoneal dialysis on ACE or ARBs to save whatever residual kidney function they have. That being said, if you have late-stage CKD, you are at a higher risk of the complications of the ACE or ARB, so you have to watch quite closely. Now, the physiology of the ACE or ARB is that it will raise your creatinine 20 to 30%, and that's just because it's working. That's how it works. And so, you know, what I teach people is before you start it, kind of calculate that number in your head and expect it. And so we're not twitchy when the creatinine does go up. We say, okay, well, that was expected. That means they're taking the drug and they're adherent. If it goes above 30%, that's when you worry about renal artery stenosis or something else causing problems. But 20 to 30% rise in creatinine is actually expected and actually means that they may have a better physiologic response from the agent. And then we monitor at baseline, right, a creatinine and a potassium. And within 1 to 2 weeks of either starting the agent or up titrating your ACE or ARB. So I'm from the north, so I like Kenny Rogers, but one of the biggest things to know is when to hold some of these drugs. So ACEs and ARBs, diuretics, and metformin, the patients, it's quite a hard concept, but the patients must be counseled about the notion of a renal sick day. So if the patient is volume depleted, has the flu, anything like that, and there is some literature on the Renal Agency website that's actually translated about what a renal sick day is, it has some lines for which medicines to stop and when to restart them. This, even though we've done it for a long time in our clinics, patients still come to emergency with AKI and they were on the agents. It's quite a hard concept to have adherent patients stop their medicines. But you have to, it's something that we have to keep working on because every time they get an acute kidney injury insult, the person is actually at higher risk of that GFR dropping more. So these are awesome drugs, but you really have to know when to hold them. Now, you also have to know when to fold them. So someone that's older and is getting repeat acute kidney injury events from an ostomy or some high outputs or keeps getting UTIs and their creatinine is twitchy, it keeps going up and down, and they don't have a really good reason for it being on the ACE inhibitor, those are people that I would likely take off their ACE inhibitor because they've been shown to have a lot of acute kidney injury. People that have, we're going to talk about hyperkalemia coming up, but people that have persistent, you know, hyperkalemia and don't have a great indication for the ACE in the first place. It was put on for hypertension, but they don't have proteinuria kidney disease. Those would be cases that I would take them away. And what do you target? So is there a target level for proteinuria before you, and when you say, oh, that's great, I've met target, the patient's adherent, will move on. Not really. Lower is always better. There's no evidence that there's some magic kind of number that has no risks. Really, below ACRs, below 100, so less than a gram a day, it seems to be a bit of a kind of a transition point between worsening kidney function or not. ACRs below 30 seem to do much better. So if you can get it below 30, you're doing really well. I often have family practitioners or nurse practitioners trying to, and then they say, oh, I couldn't get it, it's 27, and that's excellent, and we wouldn't actually titrate. If it's below 30, we actually say you're there, you're doing really well. An eGFR stabilization, so slow progression is about 1 mil or 2 loss per year. It's considered kind of slow to moderate progression, so that's actually considered quite good and stable. And again, if they have an acute illness or volume contraction, make sure to hold their ACE, ARB, diuretic, and metformin. Metformin is a very useful drug. We could talk a long time about GFR cutoffs and whether we have them or not. The times metformin is a bad drug is when you're sick, when you have less circulation, when you're volume depleted. So for patients with chronic kidney disease on it, as long as they know when to stop it, in general, it's quite a safe drug. So let's move on a bit to some of the common complications you would see in primary care. This is what we do in our interprofessional clinics day on day. We have a wonderful team of dietitians and nurses, pharmacists that help us with this. But we'll talk about probably about 90% of what we can do in primary care to keep these parameters at target. So the first is anemia management. You have a 75-year-old lady, high blood pressure, chronic kidney disease, and her eGFR is at 50 mils per minute, and her hemoglobin is 108. Check a ferritin, it's okay, and she'd actually had a colonoscopy 3 years ago and an endoscopy. So what would you do? We often get these patients as a query EPO referral. So really in these patients that are anemic, ferritin in chronic kidney disease is not reliable, really not reliable. Even in people you don't think are that inflamed. We tend to monitor it to make sure they don't have iron overload, but we use a transferrin saturation. And anything above 22 to 25%, it's thought that iron will still help drive up the hemoglobin a bit. And so if the patient wants to treat her anemia, to start, we use ferrous fumarate. You can use any of them, but traditionally in kidney clinics we use ferrous fumarate because it has the highest amount of elemental iron, up to 3 sulfate gluconate, and we usually give it at bedtime and go up to 900 at bedtime, all given at the same time. And that's mainly convention because we also are sometimes giving calcium or other things that may complex, and so that's how we manage. And with that, most patients maintain a normal iron, normal enough hemoglobin. It's physiologic to have a lower hemoglobin when you have chronic kidney disease. So we'll talk a bit about EPO. There's no absolute rules of what's in proportion or out of proportion to your anemia and your level of kidney function. But when I look at hundreds of patients, it's very unusual, almost unheard of to have a hemoglobin less than 100 if your eGFR is greater than 45. There would be something else going on as the cause of the anemia. Ferritin's unreliable, so in your CKD patients measure TSAT instead and aim for 25%, and you may require IV iron to get there. This is the dose of ferrous fumarate we use. And ESAs are used very sparingly. We're just going to talk about CKD, not on dialysis. ESAs are used very sparingly, and in our clinics of patients with GFRs less than 30, we only have about 4% of the population on ESAs. And that is because there's evidence of harm starting ESAs to drive hemoglobin up, and there's actually really no evidence of benefit to starting ESAs in patients with hemoglobin below 90 to 100. There's another meta-analysis that came out a couple months ago that showed, again, no benefit of bringing hemoglobin up to 120 on quality of life even and potential harm. That doesn't mean we don't give it to patients with hemoglobins below 90 to 100. One of the absolute indications are people you're trying to avoid a blood transfusion in. So if you have a young person who you see their hemoglobin drifting, those are people we want to keep their hemoglobin up, and we aim for a target of around 100, 110. In older patients, you really have to ask, it's not needed for their health per se, you really have to ask the question about their, one, to avoid blood transfusions, and two, do I think they're going to get quality of life benefit? And sometimes a trial is helpful. Sometimes there's less quality of life poking themselves or getting the injection once a week to keep them in that 90 to 100 range. So it's being used less and less with lower and lower targets. and I think it's even going down a little bit more. That doesn't mean it doesn't have a very important role in the management of patients with chronic kidney disease for both quality of life and especially to avoid blood transfusions. And some people feel, they can feel it. You know, you have some people who can't do their golf if they're 90 and can if they're 110, and that they need a little bit of ESA to do that, and they see that benefit, and that's an absolute excellent indication for that individual. So that's the 2-slide on anemia. Potassium is another one we get a lot of questions about and manage a lot. This is a 72-year-old. He has type 2 diabetes. He has high blood pressure. He has hypercholesterolemia. His BMI is 30. His GFR is 30 and his ACR is 200. So that's your higher category, 2 grams of albumin in 24 hours. His hemoglobin is 110. He's on a calcium channel blocker, an ACE inhibitor, metformin, aspirin, and Lipitor. His potassium comes back and it's 5.9, and the last one was 5.5. And you checked at the lab and it wasn't sitting around for a long time and it wasn't hemolyzed. What would you tell this gentleman to do? So in our kidney clinics, we would call him, take a dietary history, make sure he's not constipated, and then simply repeat the value if he's below 6. Now he needs the ACE inhibitor, right, because he has a GFR of 30 and he has an ACR of 200. So he's at high risk of progression. So you can't really just say, well, he doesn't tolerate ACE inhibitors so because of the hyperkalemia. So we have to find some way to keep him on this drug. And so after repeat, usually kind of 5 to 5.5, if it's in that range, is considered someone's wiggle room. But if it is still above 5.5 and their diet's good, then if the blood pressure wasn't great, you could try thiazide, maybe instead of your calcium channel blocker, to see if you could bring it down with medications. The blood pressure's fine, maybe a binder, either Caxylate or calcium resonium, and repeat it in a week or 2. If ACE inhibitors make a potassium above 6 or so, it's very fair to stop the ACE inhibitor temporarily, absolutely. Figure out what's going on, figure out what they ate, figure out what other medications were started, but consider putting it back on. And so a stable potassium of 5.5, around there, acceptable. It's usually quite responsive to dietary intervention. And if there's a good indication for the ACE inhibitor, continue it, titrate it down, potentially after stopping, depending on your level of comfort with the patient. We very rarely stop them, but we have the luxury of a dietitian to be calling and figuring out what they ate or what they did. You can add a potassium-wasting diuretic, and I just put the common doses of the 2 most common resins. And what I see happen sometimes is that it'll be started for a few days and repeated, and then it's down, and then it won't get continued. But really, if they've repeated episodes that are above, it should probably just be put on low-dose maintenance of about 3 times a week, and that usually keeps people out of trouble. And then for primary care providers looking after these patients, I just wanted to give a brief kind of discussion of how the landscape's changed a bit with respect to calcium, phosphorus, PTH measurements. So I would say 10, 12 years back, we used a lot of activated vitamin D. We targeted PTHs. We did a lot of measurements. The evidence and the guidelines have said really that the reason you're doing that is for patients that have progressive kidney disease to get on it early. But many people that we've highlighted will never progress. So if GFRs are between 30 and 45, the recommendation is to measure these 3 once and then not really again to get a baseline. There's no need to routinely monitor on an every 3-month basis or ever so often these numbers if they're normal in that range. Often a PTH will be done just as practice, and it'll be a little bit up. And an easy way to try to see if it's due to vitamin D deficiency is to put them on a bit of vitamin D as outlined here. And often that PTH will cyclically get a little bit better in the summer when there's more sun and then go down. So vitamin D can sometimes keep it at a level that's okay. And we actually don't know what level is okay. A couple times normal, probably okay. Really it's watching the trend, and then once they have significant kidney disease, usually in the realm of nephrology, to be managing metabolic bone disease from their kidney disease. And I just wanted to mention something that's cheap and and easy and actually has been shown to be beneficial. So not many patients are acidotic with chronic kidney disease, but some are. And baking soda has actually been, the problem with being acidotic is, of course, effect on your muscles, effect on your bone, effect on your cardiac function, and actually some good studies that show patients with an acidosis have worse progression of their kidney disease. And so a reminder that we will initiate, but if you have someone with kidney disease that's quite prone to acidosis, we supplement with bicarb if their serum bicarb is less than 22, so 21 and below. And sodium bicarb is salt, and often the patient says, what are you doing? Some people will get edematous with some sodium bicarb because of the nature of it. Some other people tolerate it just fine. So they come in tablets. You can give it as baking soda. Plain old Tums, calcium carbonate gets converted. If they have a stone form or citrate, any citrate products will get converted. That will all provide alkali. So you might see us do that, or recommend bicarb, and really it's been a cheap and an easy way to help reduce progression of chronic kidney disease. So just to finish up, we're just going to talk a bit about co-management and when referral is recommended. So the guidelines suggest kind of the 30-30 rule. So eGFR is less than 30 or ACR is above 30. And I think that's a pretty actual safe rule. Now, of course, if you're concerned, a phone call would be great, or a referral if there's persistent blood and protein in the urine. If there's an eGFR change below 60 and then it changes more than 5 mils per minute and you're not sure and you repeat it and it's still going down. And the other things nephrologists are trained at is refractory hypertension, if you just can't manage that potassium, stone disease, polycystic kidney disease, hereditary kidney disease. Like I said, structural abnormalities of the kidney or kidney cancers, urology. And so obviously if the patient has acute kidney failure and you're concerned, GFR is less than 30, contextualized within age and other parameters. So like I said at the beginning, if you have the 86-year-old whose GFR calculates at 28, but she's fine, and it's been like that, and she's okay, and you do a urine protein, and it's okay, I would just follow her blood work maybe in 6 months, but probably not need a referral. I wouldn't treat her gout with a lot of NSAIDs, but otherwise she's very low risk of progression. If you can't reach treatment targets, if you need reassurance or explanation, and now all over BC there are race lines or other ways to call in and get phone advice as well. And so this is just a, not to go through it, but it's a heat map of the kind of marriage between protein on this side and the kidney function, and to show that no protein in GFR above 60 is normal kidneys. And sorry about that. And the colors are your levels of risk, like yellow is less risky than kind of the red, of course. And so the guidelines would say if you have someone with just proteinuria, a little bit of proteinuria, you could refer at a GFR less than 30, but if they have an ACR above 30, referral is recommended. Now, of course, it all comes with nuances. A young patient, you would think different than an old patient, but for a rule of thumb, I would say that 30-30 rule, ACR above 30, GFR below 30 would actually serve a good screen. So I think just in summary, it's very common to have chronic kidney disease, and nephrologists probably manage about 1% of the CKD out there. Moderate reductions in eGFR really should be seen as a cardiovascular disease risk factor and usually does not require the intensive care of the kidney program. And really it's teasing out who is likely to have progressive kidney disease, so we can get those patients very early, and then we can get the kind of worried older patient to just be reassured and not have the full-blown follow-up. If you have an eGFR in that 30 to 60 range and minimal proteinuria, you have a much lower risk of progression and can be usually managed in the primary care setting. And so I think that's the end of this formal part. Thank you for your, I guess, undivided attention, and we'll open the floor to any questions in the time remaining. And while we're waiting, the next session is going to be on medications to use and not use in kidney disease. We'll go, and that's on June 8th. We'll go through some of the common kind of conditions patients with kidney disease get and which medications to treat the gout and treat other things and which medications are quite bad. And then we're going to talk about cardiovascular disease and blood pressure management. Any questions? No questions.
Oh, there's one here. First one is, should we lower uric acid level in patients with CKD?
Yeah, great question. So there's a question about what do you do with uric acid. Do you lower the uric acid in CKD? So uric acid will raise and will go up in CKD because the only way out is through the kidney. Patients that get repeated episodes of gout or even one episode of gout should have their uric acid reduced. The question that's probably being asked is, independent of gout, should you be adding agents to reduce, to pharmacologically reduce uric acid in the hopes of reducing the progression of kidney disease? And the jury's really out. We do not routinely treat the uric acid number in isolation with allopurinol or febuxostat. We will look at their diet and see if we can reduce some sources, but we won't add pharmacologic therapy for uric acid alone. That being said, if you have someone with stones or with a very, very high uric acid, then yes, you might add it. But in general, just that 1.5 times, 2 times normal uric acid levels, we don't independently start treating in the absence of gout. No, one question. All right. I will stay on till 1 if there are any other questions that people want to ask. Otherwise, there will be an evaluation. Please fill it out so we can help modify to meet your needs. And thank you, everyone, for signing on.